I would like to jump on a little bit to systemic therapy right away. Usually when we talk about this, we say local disease, embolization, or some form of embolization. I totally agree. There's no question about it. But however, I'm going to jump to systemic therapy, and I probably might kind of like, get a little bit of feel from the different experts. But let's ask Dr. Fernette, as a hepatologist, like if you have a patient with really quite extensive disease, but still limited to the liver, okay? And I'm going to make it a little bit dicier. No vascular involvement, no metastatic disease, but it requires like really endless number of embolization to be able to control the disease. And do you think it's crazy if you say I have systemic therapy that can help you?
I don't think that's crazy. And in fact, as the more and more data comes out with systemic therapies, we're getting overall survivals that are rivaling our local regional therapy, especially for those patients that have an extensive burden of disease. I heard one of the IRs describe it as a pepperoni pizza liver, where you're going to need more than 2 or 3 or 4 or 5 TACEs or Y90s to be able to control this disease. You want to also protect the liver function so that you then can benefit from systemic therapy. So in those cases, I think it's absolutely reasonable to proceed to systemic therapy first.
It looks like music to my ear.
Absolutely.
So, Anthony, have you had a situation with a patient who was local advanced disease and they were on some form of systemic therapy and they did very well?
Oh, absolutely, absolutely. So in our clinic, I think the parameter is if we really cannot treat the entire disease with an average of 2 to 3 TACEs, we usually go to systemic therapy. Now we know from the TACE data that the larger the lesions are, the more multiple the lesions are, the less the chance of long-term benefit from TACE anyway. So it's important to keep that in mind. Actually, at this meeting at ASCO GI 2020, there's a poster from Japan reporting an experience that with patients with BCLCB, meaning liver limited, again, this is not a randomized trial, but they looked at patients who got TACE versus lenvatinib, for example, with BCLCB disease, again, quite multifocal and extensive. The group that got lenvatinib actually tended to do a bit better from a survival and response perspective even. Again, we need more data in this front, but I think the trend is that we will take the higher risk BCLCB patients and start systemic therapy going forward.
Fair enough. And Ahmed, along that line, as we both know, there has been attempts to try to, quote unquote, combine therapies for the sake of enhancing the outcome from the local therapy, i.e. add the systemic to the local therapy for the patient with local disease. Like, as you know, for example, the space study of TACE plus sorafenib. Your thoughts on that?
Yeah, so there has been several attempts to do that, and they really varied significantly. So some of them did it in an adjuvant manner. So you do TACE and then you start randomizing treatment, no treatment. Other studies looked into combining them from day one or doing systemic followed by local. But in my mind, I really think that if you cannot manage your patient in the least number of sessions for the local therapy, it's just a marker of the disease prognosis and biology itself. If you have multifocal bilobar disease, that's from the oncology standpoint, that's an aggressive disease. So in these cases, my preference is to start with systemic therapy. And in some cases, we use local therapy as also some kind of salvage or combination strategy down the line. If the patient is responding in all lesions except one small lesion that grew a little bit, tolerating the treatment well. So that really highlights the importance of multidisciplinary care with our IR team and also our hepatologist. So as Dr. Fernette said, we have to make sure that we don't damage the underlying chronic liver disease.
Fair. And Peter, to follow up on this, the perception that we heard, and this is where most of us were, is add systemic to local for local disease. But already Ahmed alluded to, and I have probably to say that I not necessarily would say that we have the data for that, and I might not necessarily agree on the idea of kind of combining things until we have data. But nonetheless, there was a report that came out, if you recall, in 2018 in JAMA Oncology that spoke about adding local to systemic therapy for systemic disease. It came out, that you can combine the local therapy to systemic therapy, but for metastatic disease, i.e., we need to really focus on the liver disease while, of course, taking care of the other metastatic sites. Do you think there's behavior difference between the liver disease itself in the liver versus metastases?
Right. But I think the paper you alluded to is a part of a small body of evidence that suggests that maybe achieving disease control beyond the liver is of some value. For the most part, the evidence that that is indeed the case, at least in my mind, is not quite there. So we don't routinely offer patients locoregional therapy on top of systemic therapy if they have macrovascular invasion or extrahepatic spread. As systemic therapy improves in terms of providing better outcomes from a disease control and overall survival perspective, I think it becomes less and less attractive to actually combine both, at least in my mind. And indeed, I think from even the BCLC-B patients, the locally advanced disease patients, it becomes increasingly attractive to offer them systemic therapy, especially if they have what we colloquially call bad B disease, right? Where they have fairly diffuse multi-lobar, multi-nodular disease, which realistically locoregional therapy might not effectively treat.
Fair. So what we're hearing here, and this is very important, I like very much what we heard, is that it's a multidisciplinary team approach. And if anything, please make sure that when you have a tumor board, be there. I have to say that there's opportunity to really learn about our colleagues and experts in other parts of managing HCC, i.e. the interventional radiologists, the surgeon, transplant surgeons, the hepatologist, and of course, us as medical oncologists, all to be there on the table. And number two is to make sure that we get the input from everybody about what's the best approach to treat a certain patient. Interestingly, and this was kind of like something that we brought up, I remember back like almost 10 years ago, and we wrote that editorial in JCO, and we said that local plus systemic therapy, is it really a marriage? And if anything, maybe it is. At that time, I remember I wanted to write it marriage or divorce, and the suggestion from the editor was, no, keep it as marriage. And you know what? In retrospect, absolutely right, because what we heard from Dr. Ghulam, after all that discussion, might lead to a certain potential further evaluation of the combination of therapies that we are all obligated to do together. At this point, though, local disease, and as Dr. El-Kuwairi said, certain effort to try to control it by local therapy. If it remains local but it becomes a little bit uncontrollable, i.e. the recurrences happen quick or there's too many recurrences, it's time to move to systemic therapy. On the other hand, a patient, and I like what Dr. Fernand said, that might kind of have a systemic disease, come back a little bit on some further control locally, even though it might be quote unquote out of the book, but it does not mean that, but make sure that we keep all options open. I always tell personally the patients with HCC, everything with HCC remains on the table. We cannot say, oh, you're done with local, now it's time systemic. You have to make sure that you kind of keep mobilizing things as appropriately needed for a specific patient.